Macrocytic anemia is really about B12 and folic acid deficiency. It's key to be able to separate the diagnosis between the two, know a little bit more about B12 deficiency, and then just be able to rattle off a couple of the diagnoses that can cause non-megaloblastic anemia. Let's start off with how we got here. If someone has the signs and symptoms of anemia, or we just checked a CBC on routine labs, we're going to find that the hemoglobin is low. And if the hemoglobin is low, we know the next thing to do reflexively is to look at the MCV of that CBC. In this instance, the MCV is going to be elevated, giving us a macrocytic anemia. Macrocytic anemias are production anemias, and so we can be sure that the reticulocyte count will be low. When you see big cells, macrocytosis, you need to separate it between megaloblastic and non-megaloblastic. You do that by looking at a blood smear. In real life, an abnormal CBC is going to reflex to a smear, but on the test, you may need to choose it. If on that smear you see hypersegmented neutrophils, 5 or more lobes, that is impaired DNA synthesis, and you have a megaloblastic anemia. Macrocytosis and megaloblastosis are not the same thing. Macrocytic means big, megaloblastic means impaired DNA synthesis, 5 or more lobes on your neutrophils. If you do not have impaired DNA synthesis, you won't see hypersegmented neutrophils. That is a non-megaloblastic anemia. Megaloblastic anemia is B12 and folate deficiency. So the first thing you do is check a B12 and a folate. If the B12 is low, you have a B12 deficiency, and you need to replace the B12. If the folic acid is low, you have a folate deficiency, and you need to give folate. But if the values are equivocal, that is, they are on the lower end of normal, you don't know which one it is, and we'll talk about why it's important to separate the two, you get a methylmalonic acid. The methylmalonic acid is elevated in B12 and not elevated in folic acid deficiency. Non-megaloblastic causes, there are a few. The ones you should know are liver disease, which means cirrhosis, alcohol, drugs, and some metabolic inheritable conditions. We'll talk about these more in detail at the very end. So this whole lecture is going to be about folate and B12. Let's start with folic acid deficiency because it's easier. Folic acid comes from leafy greens. You ingest it in your diet. And we have about a 3 to 6 week supply in our stores. So no matter how much folate you eat, your body can only hang on to about 6 weeks worth, which means that any person who doesn't continue to ingest folate can end up with a folate deficiency. The other way this happens is when there are increased demands of folate, as in pregnancy. So this may come up on your internal medicine shelf or on your OB shelf. The patient who gets folic acid deficiency is either going to be pregnant and increase the demand. That's why part of prenatal vitamins is a folic acid. And at that point, the folic acid is more for baby than it is for mom. But the patient you're looking out for is a person who's on a tea and toast diet. And this person is going to present with an anemia only. You're not going to see anything else. The tea and toast diet are going to be in two varieties. It's either going to be the chronic malnourished alcoholic who gets all of their calories through alcohol, or it's going to be the little old lady who just lost her husband, who's at home depressed, barely eating, and when she eats only what she can pull out of a package. Most grains in the United States are fortified with folate. So even if someone's eating cereal, they're getting enough folate to maintain themselves. It has to be someone who eats literally nothing in order to get a folic acid deficiency. The diagnosis is made by getting a folic acid. If the folic acid is low, you just treat. And the treatment is folic acid. 1 milligram orally, daily. But if the folic acid level is equivocal, the test you want to get is a methylmalonic acid. And the methylmalonic acid will not be elevated. If you were like me, you studied very hard for step 1, learning the Krebs cycle, the SAM cycle, etc. At that point, homocysteine was useful to test your ability to know the Krebs cycle and the SAM cycle. Now, I don't say those words unless I'm making a joke. So I don't remember that stuff anymore. And I don't remember that stuff anymore because it's not clinically relevant. Yes, it is true. In folic acid deficiency, the homocysteine will be elevated. But since we're talking about macrocytic anemia, and we're trying to separate folic acid deficiency from B12 deficiency, and the homocysteine is elevated in both, just don't learn it. What you care about is the methylmalonic acid. Let's talk about B12. We have about a decade's worth, 3 to 10 years of storage of B12, and B12 comes from animal products. So unlike folic acid deficiency, it is pretty hard to not get enough B12 simply by not eating. We care about B12 so much because B12 deficiency, in addition to the anemia, causes the neurosymptoms, the subacute combined degeneration of the cord. Neurosymptoms which, once they set on, cannot be reversed. So there's going to be 2 types of people who get B12 deficiency. You have to have the strict, uneducated vegan. And I say uneducated because they have to be very rigid to eat no animal products whatsoever, and then not know enough to take a B12 supplement. So strict, uneducated vegans for a long time can have nutritional deficiency of B12, but where you're going to see this more often than in the strict vegan is in disease states that compromise absorption of B12. And compromised absorption comes in 3 forms: pernicious anemia, Crohn's disease, and gastric bypass. We'll talk about how this works in just a minute. The diagnosis is going to be made by checking a B12 level. If the B12 level is low, you are just going to treat. And you treat by giving B12. As we'll discuss, you'll have to decide whether you simply replace it orally or if they need injections. B12, if the B12 level is equivocal, you want to check a methylmalonic acid, because the methylmalonic acid will be elevated in B12 where it is not in folic acid deficiency. The homocysteine level is elevated in B12, but stop learning that because it's elevated in both B12 and folic acid deficiency. Okay, let's talk a little bit more about the disease states, the pathology, and how you decide if someone needs to get PO or IM. This is a stomach, bunch of intestines that ends with the terminal ileum, which then connects to the colon. Parietal cells secrete intrinsic factor, and you ingest B12. It is the combination of intrinsic factor with B12 that allows B12 to be absorbed. And the combination of B12 and intrinsic factor are absorbed at the terminal ileum. So you must have an intact stomach secreting intrinsic factor, and you must have an intact terminal ileum. In pernicious anemia, IgA attacks the parietal cells, killing them. If you don't have parietal cells, you don't have intrinsic factor. If you don't have intrinsic factor, you don't have the combination which is required to be absorbed. In Crohn's disease, inflammatory bowel disease, it has a predilection for the terminal ileum. Inflammation of the terminal ileum or resection from a complication like a fistula results in the inability to absorb B12 and intrinsic factor. So even though you have an intact stomach, you still don't have the site for this combination to be absorbed. And if you had gastric bypass, you've bypassed the stomach where the parietal cell's intrinsic factor is. So if you have impaired absorption, you have to give it back IM. If they're simply nutritionally deficient, you give it to them oral. Now we care about this so much because of the neurosymptoms. This is a spinal cord. If you remember, the DCMLS, the dorsal column medial lemniscus system, is up here. This is responsible for 2-point discrimination, proprioception, and vibratory sense. So someone who has this is going to look like they've got syphilis, in that they have the same similar symptoms. They're going to be flapping their feet around on the ground because of loss of proprioception. They're going to be banging into things because they don't know where they are in space. They can feel pain, they can move, they just have lost proprioception. And once you lose these nerves, it's a demyelinating disease, you don't get them back. Now, one more thing about B12, and this comes up on the test only, you're never going to do this in real life, and that is the Schilling's test. You may be asked to interpret it. And a Schilling's test, what you're trying to do is decide, do they have impaired absorption or is it nutritional? Most of the time you get that based on the history alone. It goes something like this. You give someone an IM injection of B12. You saturate all the B12 in the liver. Then you give them oral B12. And you check their urine. Because it's saturated, any B12 ingested at this point will simply be peed out in the urine. If the urine is positive for B12, they were able to absorb it, so the previous problem was just nutritional deficiency. If the urine is negative, they were not able to absorb the oral B12 you just gave them, so they have an impaired absorption. Do not pick the Schilling's test as the next step, but you may be asked to interpret it. And lastly, we're going to close with a laundry list of the non-megaloblastic causes. This is included for completeness. I would not memorize this. Liver disease means cirrhosis, so cirrhotics may just have a big MCV. Alcohol can do it even in the absence of cirrhosis. Drugs can do it, and the ones you should look out for are chemotherapeutic agents like 5-fluorouracil, Ara-C, and retrovirals, and the one that's usually associated with it is AZT, zidovudine. And then the metabolic conditions. Lesch-Nyhan syndrome and hereditary orotic aciduria. Now you notice I'm not even writing them out. Don't memorize this. So this lecture came down to folate versus B12. Folate more acute than B12. Folic acid, methylmalonic acid not changed, give them folate. B12 deficiency, long time to get deplete, methylmalonic acid is elevated, and you need to decide, is this going to be impaired absorption, so give it IM, or nutritional deficiency and give it PO. That is megaloblastic anemia.